we have 25 minutes, David, for us to have a conversation on a topic that's massive. I'm going to, if it's okay with you, spend about 15 minutes or so for us to have a conversation, really open it up to this engaging audience.
Let's do it.
To set a little bit of the context, David, for our conversation, I mean, you're clearly aware that when we think about health as an industry, while we were talking about banking and financial services, I mean, the top three sectors in the world, which are agri and food processing, the health industry, which is a $9.5 to $10 trillion industry globally, followed by oil and gas. We see that the top three sectors are relatively untouched by technology and IT, right? I mean, computing and connectivity hasn't really had that much of an impact. So we have, however, really in the last 100 years of medicine seen significant advances in health, right? But still at the turn of the century, we have big unsolved problems in medicine, right? So what I want to do is to really focus our conversation on three key topics, if it's okay with you. The first is really to set a context for this audience on really what are at the turn of the century, what are really for the 21st century, the big unsolved problems in medicine. Second, you've written prolifically about, and you've been an advocate for really how technology can and should create an impact in transforming health. So I'd like to get your perspectives on that. And I know you've spent some time on cancer, which is one of the very big unsolved problems.
I'm against cancer.
We all are, right? And I'd like to understand your thoughts on cancer, which is a big data problem. What are your thoughts on really the role that the Internet of Things can really play and technology in general in transforming the problem, addressing the problem of cancer? Is that okay?
Yes, these are some big topics, but I'm ready. Let's do it.
Great. And then I'll open it up to the audience for a quick conversation. So I want to start with really, as we look at the last 100 years, we've seen everything from vaccines to antibiotics to cardiac care seeing significant improvement. But that still leaves some significant unsolved problems as we look at the 21st century, right? So can you just paint a picture for us of really what you see as the big problems in healthcare?
I mean, there are a couple big problems. I mean, the first one is something that is just near and dear to everybody because it's in the news every day over the last several weeks, which is something like Zika virus. Remember, in 1918, we lost 100 million people in the world to influenza. At that time, you weren't allowed to go to church services. You weren't allowed to go anywhere to congregate more than 3 people. That's how they fought it. Everyone was basically confined to their house for a year. It took, on average, 14 years off life expectancy, one flu outbreak for the entire world. So, I mean, things like Zika virus are happening. You're going to be astonished by what happens this summer. 250 pregnant women have Zika now in the United States. That's going to go into the multiple thousands, and many babies are going to be born without a fully developed brain, and it's going to be scary. So the world now is flat. It is a remarkable time of people going all over the place. And when you have a thing like the World Cup happening in Brazil, everyone congregates and it spreads back. That's what happened with Zika, and we're going to see that over and over again. So we as a world have to adapt to the changing transportation, to climate change, to all of those, to adapt to what's happening in infectious disease. Number two is, I think the fundamental problem in medicine is a mistake we made 90 years ago. And it literally has lasted with us. There was an experiment where there were 12 people, and they each had a significant cut on their leg. Half of them they left open to the air, and half they took a piece of bread, they dipped it in water, and they wrapped it around the leg. Well, the people with the bread on their leg healed twice as fast, and it screwed up medicine. Right? That bread made mold, the mold made penicillin, and it spawned something called germ theory. Germ theory said as soon as you know what you're up against, you know how to fix it. So look into the microscope and see what bacteria it is. You know exactly what to give the patient, and it's right. The problem is Alzheimer's, heart disease, cancer are from within, not without. And so the way we're going to treat these diseases is we can measure the whole system and not the cell. Well, I don't even know the language to measure a system and even describe it. So that next advance in medicine will no longer be targeting a cell with cancer or targeting the LDL and cholesterol problems and heart disease. It's going to be modulating the system. You know, you drop a match after it rains, nothing happened. You drop a match in my hometown of Los Angeles, it goes up in flames. Context matters, and we don't know how to describe context in health. So as we moved into this big data revolution, we're just getting the low-lying fruit. If we really want to get what's up here, we have to start to describe context in the system.
There is also the added problem of costs of healthcare versus these problems to solve. Can you also describe that economic challenge with healthcare as well?
You know, we in our country have a right to do whatever we want. You can smoke, you can be obese, you can sit all day, and then society has the obligation of paying for the healthcare ramifications of your decisions. Well, first of all, that has to stop. The state of California has the lowest smoking rate in the country, yet almost a third of our healthcare costs are tobacco related. So we can lower healthcare costs dramatically by changing behavior and by starting to tell people. You know, I was at Cleveland Clinic last night. I came back this morning. And at Cleveland Clinic now, if you smoke, you can't be hired. So they will not hire a smoker. It's legal. They do it, and it has a dramatic impact. In the county they're in, the smoking rate went from 25% down to 12% when they instituted that. So you can impact things that can make change. Technology should dramatically drive down healthcare costs. I mean, it's as simple as that. It's scalable and it works. You know, right now a pathologist, if you have a biopsy, a pathologist takes a needle, they stick it in, and you look under a microscope, and they use pattern recognition, normal versus what they call cancer, which is basically, you know, this is the difference of normal and cancer, right? This is normal, this is cancer, the cell's smushed a little. That's the state of the art now, and you pay somebody $1,000 every time they do that, $1,000 every time they do this. It makes no sense. So with AI machine learning, you know, slides can be scanned in, and it can basically democratize reading of pathology across the world and bring down costs dramatically. And we can scale that on imaging, we can scale that on many of the things we do to lower costs. And that's certainly exciting and encouraging. There's also the notion of longer you live. You know, the longer you live, in general, healthcare costs go down in our country, not up. If you live past the mid-80s, we don't put you in an intensive care unit, we don't put you on a ventilator, these crazy things that cost the individual and society a tremendous amount with almost no benefits. You know, in general, the younger you get a disease, the more expensive it is. And so the good thing is, if we make people live longer, costs will come down.
That leads me directly into some of the stuff that you've written about, which is the big challenge of big data, big disconnected data when it comes to healthcare, right? How do we tie the data together to draw meaning out of it? Where would you start when you begin to address the problem?
So, you know, ovarian cancer, a horrible killer in our country. It turns out if a woman is on a beta blocker, which is an inexpensive generic drug to treat blood pressure, she lives 4.5 years longer than if she isn't with ovarian cancer. Where do we get that? It was a big data study. Somebody just looked at the large cohorts of ovarian cancer patients across the world and came up with that. We would have never had it in biology. So big data can be transformative. The problem now is that most of the data is collected without context, in a non-standardized way, and using non-standardized data elements. And I think that's what's challenging. You know, you call it a broken leg, you call it a fractured leg, our databases don't talk. And so in order to get real utility, we all have to standardize on things, which seems easy. You know, in the Department of Commerce, there's the National Institute of Standards and Technology, whose job it is to say, hey, here's a standard, let's do it. And they classically take it from the private sector. The problem is, in our field, we have standards. So somebody needs to stand up, and there's a lot of careerism involved, because if you spent your career working on one and everybody just said use another one, you're pissed off. But somebody's got to have the leadership to do it, and we need leadership in healthcare, which we don't have right now. So big data will transform it. At the same time, you know, you've heard a lot about security. Well, security is going to be an issue. You're going to see it soon where you end up in an emergency room because you have a cut in your arm. You go there, they look at your medical record, they give you an antibiotic, an hour later, you're dead. Because what happened is people are breaking in, obviously, to the Blue Crosses of the world. They're holding hospitals hijack, where they have to pay a ransom of millions of dollars in order to get access to their EMRs, but they're going to go in and change your medical record. So they took your allergy to penicillin and they took it out. So when that doctor saw you, they gave you a penicillin. Or they could take a Donald Trump of the world and give him a disease, and actually that'll proliferate out there. Or take a CEO and say they've been promiscuous with regard to sex. You name it, That can happen now and that will happen. We have to separate that out from the heroes of the world who donate their medical information and their data to actually be mined and learned. I think both can happen concurrently, and it needs to. But big data will be a revolution in our space if we use it correctly. At the same time, computers won't take over. AI will not treat patients. It will never happen. I guarantee you that. There will always be an art to medicine. And when you start to see, in the medical literature now, when a computer looks at things in the medical literature, they look at everything relatively equally. You can put a hierarchy based on the journal, et cetera. But an amazing study came out. If you look at the medical literature over a period of multiple decades, 80% of the studies turn out to be incorrect. So you cannot just rely on a study that will change context and will be interpreted differently over time. You have to still rely on that art of medicine.
So if I put myself in the shoes of the technology sector, which is looking at how do I pick up big problems to solve for healthcare,
right?
What are the 2 or 3 big areas that you would recommend for?
Well, first of all, you frame the question right. Is you want to solve problems. Most of the technologies I see are not solving problems. So you got to say, what is a fundamental problem? And so a fundamental problem is electronic medical records, right? Data in it is unusable. They were written in the 80s, and if you guys went in and tried to use my electronic medical record, it's like using MS-DOS. You would be shocked at what's in there. And so we have to make it usable where there's an interface, both for the physician and the patient, so they can improve. When you educate people, you get compliance. When they understand why it happens. Doctors in today's world are losing the amount of time they can spend with a patient to do it, so the transformation of using technology to educate will be very, very powerful. A technology comes out every month that people are excited about, whether it be the new Fitbit or the new Apple Watch, et cetera. Engagement is classically several months, and then it goes away. People don't care about it anymore. And so the main reason for that is that there's no context or the information isn't put in a format that can benefit us over time. If I said to you, are you healthy? You don't even know how to answer that question, right? Is there a blood test for health? Is there a marker for health? Is it how you look? Is it how do you feel? How do you really define what that is? So we need to develop ways to have these metrics, because with these metrics, we can actually get engagement. My daughter got her license to drive a car, and our insurance company, insurance in California, is through the roof. They said, if you put this little device under the steering wheel, we will give you a significant discount on your insurance. So every time she slams on the brake, I get an email. Every time she accelerates, I get an email. Every time she goes outside of a zone or past a time of night, I get an email. And that does nothing. But at the end of every week, she gets a score of 0 to 100 of how safe she drove. And she competes with her friends. I got an 88. What did you get this week? I got an 89. Well, how did you do it? Well, after the stop sign, you slowly accelerate instead of doing it quickly. And they game the system to drive safer. And the engagement is staggering. I talked to the CEO of the company, made it. This was an afterthought, a little thing, and everything they had planned for years didn't work. This one thing did. Well, we need to do the same in the sphere of health. We need to look at how we get engagement, how we get consumers and doctors to do it. An amazing study came out. This is one of the things that really influenced me, is that there are 300,000 appendectomies done every year in the United States. We take out an appendix for appendicitis. In the 1950s, this Russian explorer who's a doctor was in Antarctica, and there's an amazing picture of him taking his own appendix out, because we were told that whenever you have appendicitis, you got to take it out right away, 24/7. That doctor needs to rush in and take it out. Well, in Europe, they did a study where they gave people with appendicitis antibiotics. 70% of the people never needed surgery at all. And of the 30% who eventually needed surgery, there were 0 complications for waiting. Well, we've been doing this for 70 years. Nobody even questioned it. But the amazing thing is, this study came out a year and a half ago. The rate of appendectomies in the United States still hasn't changed. So on average, it takes a doctor 12 years for 50% of them to adopt a new technology. So healthcare will change from the ground up, not the top down. And the problem is, the companies, the Philips, the GEs, the Siemens of the world, keep going to see what the doctors want. And a few doctors say it, and then the rest don't want to do it, and nothing gets enacted and nothing happens. We have to change the cycle.
I want to quickly touch on cancer.
Yes.
how are we going to solve the problem of cancer? What role do you see technology playing?
Well, and obviously it's a very broad question, but all of a sudden, for the first time in my career, I can walk into a patient's room with a true sense of optimism. A year ago, Jimmy Carter said, I have melanoma that went to the brain, and he was a hero for being transparent about his disease. And literally, the year prior, that was a death sentence. He got a drug that blocks the don't eat me signal on the cancer to allow his own immune system to come in and eat the cancer. And 3 weeks ago, he announced he's cancer-free and no longer on treatment. So certainly, there are advances happening. There's immunotherapy, and there's what we call molecularly targeted therapy. It's the notion of identifying an on switch that the cancer has an addiction to and giving a drug that can block that. Well, in order to do that, you need DNA sequencing. So right now, DNA sequencing is what's going on in our space. Every patient I see, we sequence their cancer, and in about 40% of cases, it can guide what I do with treatment. Well, the next generation will be looking at the proteome, the proteins in the blood, which is the conversation in the body. Well, one image of the proteome is about 60 gigabytes of data for one patient. You couple that with about 200 gigabytes of data for a whole genome sequencing. And then there's going to be the microbiome. So it turns out that you have tenfold more bacteria in you than human cells in you. So these bacteria control your metabolism, what you eat, many things about you. And right now, for the first time, we're starting to sequence them and look at them. You have 20,000 different bacteria in you. But an amazing study came out last year where they took 20-year-olds and they gave them artificial sweeteners. Right? When they came out, they were the greatest food ever because they hit your sweet tooth and they weren't absorbed. And after 2 weeks, they all had markers of diabetes. They gave them antibiotics followed by the artificial sweeteners, no markers of diabetes. So what they do is they change the bacteria to push your system to diabetes. So as we go forward in cancer, we're going to modulate this system to how we metabolize drugs, how the cancer grows, and change that system. If I take a woman with early breast cancer and give her a premenopausal breast cancer and give her a drug that builds bone, that doesn't even touch the cancer, I reduce the rate of recurrence by 40%. So a drug can improve survival in a cancer that doesn't even touch the cancer by changing the system. We're learning ways of changing the system now, whether it be the microbiome, whether it be the proteome, or others of those. The problem is it's staggering data. And there are data right now in silos. The future is molding that data together into a model. And that's going to be challenging, but it's going to be the next advance in what we do.
Fabulous. Very inspiring. I want to now turn it over, David, to the audience. Do you have questions for David? I would only request that, given the amount of time we have, that you come straight to your question.
Yes.
I'm struck by the point about 12 years for doctors to update their thinking. Is there any way to shorten that?
Well, we're pig-headed, we're stubborn, and the way reimbursements work now is there's very little incentive to change. If you're a surgeon, you get paid $25,000 for doing an operation. You get paid nothing if you say, listen, let's observe the condition and we'll wait a couple years and see if it changes. And so we're incentivized to treat. So whether you bring in a technology that makes it better to understand a disease or better to follow a disease, we're not really incentivized to use it. So you have to change that system. The majority of healthcare costs are spent to treat disease. Almost nothing is pushed in the front to the prevention side where a lot of innovations are happening. So the system needs to be changed. But in order to get normative behavior change, you need leadership. I challenge anyone in the room to say right now, who is the Surgeon General? To say, who is the Secretary of Health and Human Services? Maybe a few of you know. In the days of C. Everett Koop, everybody knew. And so in order to get normative behavior change, you need leadership. We sorely need leaders. When the greatest leader in the healthcare domain over the last decade is the former mayor of New York City, you know there's a problem in our space.
Absolutely.
I think we really don't use technology enough in medicine today. I think we have a lot of functionality sitting out there that we're not using because, like you say, we just keep doing things the way we've always done them. For example, I think when you go to a doctor in most countries in the world, there's a chip and a card somewhere where they can see your records for the last 10 years and make correlations according to how you're proceeding, with any kind of risk assessment. Additionally, there's what I'm hearing very hot in the medical industry are garments and clothing that are being made that can monitor your body function, potentially going up to some type of application with a dashboard where somebody calls you and say, hey, those French fries you had last night had a lot of salt. Your blood pressure is going up right now. You need to do something immediately before you have a situation like that. And I mean, across several conditions. I mean, that's only sounds too easy, very uncomplicated, but I don't think we're looking to be preventive enough. We're looking to treat the disease. We're not looking to prevent the disease. And I think the technology and some of the promise of what we have out there today really needs to come to market a lot faster and be adopted a lot quicker by the medical community.
I don't even know how to answer the question because I'm not sure the question was. But I think you're right. I do think that everything you mentioned and most technology as I see, they're not solving problems. So over and over again, I get shown a garment. I get shown them literally every week. But nobody has shown me how that actually makes someone better and changes the disease course. They tell me how it could and how data is great, use it. But the challenge is for the companies out there is take a problem and show how it improves things. If you show how it improves things, I'll help you get adoption, so will every other doctor. But monitoring things without showing that there's a utility to it really doesn't help us move the needle. Yes, you can show me that the French I make correlate with a little bit of blood pressure change, but you then got to show that modulating that blood pressure change has an outcome with heart disease, with stroke, with some of those. Showing you change in number doesn't mean anything to me. And the companies out there are focusing on that over and over again. Show that you change an outcome.
We have a question all the way at the back.
My voice is very loud, but I'll try. I love the idea that you mentioned about healthcare shifting from the top-down method of innovation to bottom-up. There's this idea of hacking health, where you have people now taking control of their own situation. You have people, like websites like Patients Like Me. You have groups who are same affliction coming together and trying to think about ways to address either using technology or else, like sort of crowdsourcing their own problems. Do you see a movement in that direction? Because that direction, gets around the whole FDA. There's all kinds of things that approach could benefit from. Do you see that as a direction?
I'm not sure it gets around the FDA. Because there are recommendations made classically that will go under regulatory oversight. But I do think it's a staggeringly important movement. Remember, the doctor's office now, you come to see me, I draw your blood, I check your blood pressure, I listen to a bunch of things, and then classically, a few days later, he or she calls the patient with the data. Well, very soon, we're going to collect our own data, and then going to the doctor, we'll put it into context and actually have a conversation about the data. And those are the areas, whether it be crowdsourcing, discussing with others before you go to your data, that you're going to get a lot more information and go in with the right questions and I think improve generally healthcare. And that's that movement from the bottom up. But there will be, for most of these things, and there should be some regulatory oversight. The Patients Like Me concept is great, but it's very easy for a salesperson for a drug to get in there and pretend to be a patient and talk about an experience and push patients one direction or another. It's very different for patients to think that the condition they have and somebody else has are the same, and they could change something based on what someone told them, but they have a nuanced difference there. And so we really need to be careful. But if it's done right in a moderated fashion, I think it's very powerful.
We had a question here. Yeah.
Hi, I don't have a microphone, but I'll...
It's coming around. Go ahead.
What you're saying is making the assumption that humans are logical, that we use data to drive the decisions. But I see a guy over here is wearing 2 watches, and there are motivations that extend beyond just logic. It's perhaps in the opening they were talking about what's facile, what's safe, what leads to trust in way of product development. But the engagement factor, the psychology of fun, how does that drive and how can that becoming more incorporated into medicine and the product development when you're thinking of this moving forward in a predictive nature for longevity of a product in the healthcare sector?
It's a critical question. I think that in my mind there are 2 answers to it. The first is information. One of the big technology companies said to me, help us change our cafeteria. So we did this stupid idea of having the salad subsidize the burgers. So it was half as expensive for salad, twice as much for a burger. People got pissed off. Nobody changed what they did. It was uniformly negative. Then we did something clever, is we put a little sign next to each thing in the cafeteria just explaining what was good and what was not as good with the product, and behavior changed literally overnight. with physicians, we put in our hospital, I started to put at the bottom of it, when a doctor biopsies, the patient biopsy rate, how many biopsies are positive. So if one doctor biopsies, 80% of his or her biopsies are positive, and the other is 20%, one of them probably biopsies a little too much and one not enough. So we put the doctor positive biopsy rate and the community positive biopsy rate on the pathology report that the doctor got. And when we started, there were 3.5 standard deviations. After 30 days, we were down to 0.8 standard deviations. We didn't tell doctors what to do. We just gave them information and feedback. And so that's critical. And then we need to start to develop, there was a concept called real age a while ago, where you had one number that could say, look at a lot of your healthcare parameters and give you that metric. I think we need to improve those concepts and have actual numbers so we can game the system and make it fun. So you can start to say, listen, this week, just like my daughter in driving, I'm an 88. On health, I want to get to a 91. And so I think if we can pull in data from various sources into one number, we can start to compete. And then at the same time, reward people, whether it be the insurers or whether it be the companies. There's two health plans in Florida that made a deal with the supermarkets, and when you buy 80% of the foods in their, quote, good category, they give you a discount on your health insurance premium that month. And so we can reward people for what they do, and it's another way to game the system in a positive way and to really show them. Remember, one case of colon cancer costs a company $160,000. One heart attack costs a company $92,000. So there's a lot of incentive on a corporation part or an insurer part to make people do the right thing.
All right. I think our time's up. If I were to ask you one final question, your one wish for technology to address the problem of health.
I think the one wish is, go to the clinicians, the physicians out there and say, what are the problems? Go to the patients and say, what are the problems? And make a hierarchy of the problems and focus on the problems. Don't just focus on the technology.
Fabulous. Thank you, David.
Thank you.
Fascinating.